Hello again, it's Adam with our Test 2 review for Pharmacology 2. Just wanted to start by saying that my pregnant wife absolutely loved all of the gifts you guys got her. We both think you guys are absolutely phenomenal, and we deeply appreciate all those gifts from the bottom of our hearts. Certainly Lily is going to be quite styling in her new digs. So just to kind of cover a little bit about the different sections that we've talked about. First one being neurology. Some of the things to know, certainly with the anti-epileptics, there's a lot of different kind of new drugs that we were talking about. Certainly lots of different drugs with different mechanisms of action. So it's a good idea to have some at least basic understanding of the different ways that the drugs are going to work. So obviously things like your benzodiazepines are going to work far differently than something like phenytoin does, even though essentially they're both working to do the same thing, which is to stop a seizure. But as you'll read on and study and know, is that benzodiazepines work primarily through enhancing the effects of GABA, whereas if you had something like phenytoin, it's working primarily to block sodium channels. So again, they're by different mechanisms basically doing the same thing to make that neuron more hyperpolarized and more difficult to fire, and that's what's going to kind of interrupt those kind of reentrant mechanisms that are causing the seizure to occur. So again, having a basic idea of the different mechanisms and how those are going to be working, and realize when we can add on different drugs with different mechanisms in order to get some degree of synergy there. Certainly with the adverse effects, it is good to know things that are very unique to specific drugs. So some things are very prone to causing rashes and Stevens-Johnson's, like that would be good to know. Obviously a lot of them are going to be able to cause things like sedation. So that's not really something that you should know as a class effect, but not necessarily really try to hone in on being one specific drug or another, because they're all basically going to do that. But certainly things are going to be affecting, electrolyte shifts, or things are going to be, especially things causing hepatotoxicity and things like that. Those are all good things to really have down. As a class, you're going to know what the antiepileptics do as a side effect profile, but certainly be focusing on those kind of unique circumstances, because those are the things that are pretty important to those specific drugs that you want to remember. Moving on from that, looking at the significant drug interactions that are present. Again, a lot of these are going to be metabolized through the CYP P450 system. Various different varieties are going to metabolize certain drugs. So 3A4 will be important, 2C9, 2C19. Not necessarily so important to get hung up on the different enzymes specifically, but certainly know which significant drug interactions you're going to look for. So things that are, can significantly extend the half-life of a drug, or things that can induce metabolism either of itself or other drugs in order to make it more difficult to achieve appropriate drug levels of a lot of these things. Because if you can kind of pick out where some of these drug interactions are coming from, you might be able to find out why your patient's having so significant adverse effects, or maybe they're not having enough effect and they're having breakthrough seizures. Of the various medications that we talked about, if we did list a therapeutic range, I would expect you to be able to pick out drugs that, I'll give you a reference level and say, based on this, is the patient, therapeutic? Are they super therapeutic? Are they subtherapeutic? And based on that information, along with like kind of a clinical scenario, what are you going to do about that? Are you going to change the dose? Are you going to leave it the same? Those are kind of the questions that might come up around specific reference ranges for different drugs. So say for instance, I have a patient who comes in on carbamazepine. We know that the normal range for carbamazepine, say, is from between 4 and 12 micrograms per ml. If we were to have a patient who came in with a level of 3.5, but they've had very well controlled, no breakthrough seizures or not having any adverse effects, what are you going to do about that? And so you could either increase the dose, decrease the dose, add on valproic acid, or do nothing. And so again, just remember that those reference ranges are essentially meant to target, the majority of the population, but you're going to have people that fall outside of that. So some people are going to be therapeutic at low levels. Some people are going to be therapeutic at high levels. It just goes to show you that, there are going to be some snowflakes, so to speak, out there who are going to react a little bit differently. So it's important to keep in mind that you're not treating the number so much, but you're treating the patient. We'll also look to see different drugs of choice for specific seizure types. So if you saw that one drug in particular was a treatment of choice for a specific type of seizure, those would be good to hone in on as well, since you'll see that a lot of these drugs can be utilized for a variety of different seizure types. So those unique ones you definitely would want to hone in on there. Other things to look at would be management of status epilepticus. I'm sorry, I missed the monitoring parameters. So monitoring parameters are really important as well. This is going to be looking for things like obviously evidence of organ dysfunction, like hepatotoxicity or renal function, but certainly be looking at things like their CBC, because some of these drugs are going to cause pretty significant blood dyscrasias. So those would be the things you want to know to look for those specific drugs. Certainly things like rash and blisters can be a big portent of serious adverse effects, but even looking at things like gingival hyperplasia, like that can occur with specific anti-epileptics and can be a reason for discontinuation of therapy. So being aware of the monitoring parameters that are specific for the individual drugs is important. And then looking at management of status epilepticus, this is very important if you're ever working in more of like an ED type setting where these patients might be coming in. Realize that there is kind of an algorithm to treating those patients, with really the mainstay of therapy, the initial drugs you're going to be using being your benzodiazepines, and then moving on from there, you're going to have some backup agents like things like Keppra can be utilized, or things like your barbiturates, or things like propofol can potentially be used. We'll talk more about propofol when we get to surgery drugs. But essentially just realize that, really you kind of go by a stepwise approach. And if you don't get initial control with one drug class, so you're going to move on down to the next. Then with the other neurology sections, Parkinson's was the big thing we talked a lot about. Here, again, there's a lot of new drugs that we discuss, but it's really important to be aware of where the meds really fit in with affecting basically the pathophysiology, or basically the kind of altered neurochemistry that the patient has. Realizing that your carbidopa levodopas are working via one specific mechanism, versus something like ropinirole is working by a completely different mechanism, but they're basically achieving the same thing. So being able to pinpoint out what the different mechanisms of the drug and where they fit within that therapy. Certainly knowing things like which ones may be neuroprotective, which ones may be neurotoxic is important too. We talked a lot about how drugs that are increasing the amount of dopamine that can be metabolized can potentially lead to things like free radical formation, and can lead to neurotoxicity, in which some drugs might actually be able to avoid that. It might be able to be neuroprotective. And then also looking at which drugs are going to be working for specific symptoms. So again, if your patient was only having symptoms of tremor, certain drugs are going to be better for that patient than necessarily going down a different pathway. Also want to look at things like dietary interactions. So we talked a little bit about things like scheduling out meals, because protein can be a big interaction with having absorption of things like carbidopa, levodopa. We also talked a lot about tyramine reactions that can occur when you're using drugs like selegiline, because it's a monoamine oxidase B inhibitor. Just remember, kind of the different foods that are involved in that. And then looking at kind of how to manage a lot of the later stage complications. So if you're having issues to where the drug is becoming, say, you're at a stage where you're treating your patient with Sinemet or that carbidopa, levodopa, and they're having the effects be diminished to where, they take the drug, say, twice a day, and then, halfway through the dosing interval, they start to have their off, quote-unquote, symptoms, their dystonic symptoms. How do you manage that? Do you simply just increase your dose of Sinemet? Do you give it more often? Do you add on monoamine oxidase B inhibitor? Be aware of the things that can help that situation, and realize what the underlying pathophysiology of what that problem is. So you're having early off. The problem is you don't have enough dopamine around to keep the motor functions intact. So you need to do things to increase activity of dopamine, whether it be a direct dopamine agonist or whether it be a drug that increases levels of dopamine. You need to do something to increase that. So being aware of what the problem is and how you're going to treat it based on the mechanisms of the drug that we've talked about. Looking at Alzheimer's, there's a couple drugs that are involved with these, most of which being acetylcholinesterase inhibitors. So it's good to know what type of adverse effects you'd expect from that. Obviously, if you're going to be inhibiting the effects of acetylcholinesterase, which we know to metabolize acetylcholine, you'd expect the effects to be overactivation of those receptors. So typically, a lot of muscarinic symptoms. So you have like your dumbbells, which we've mentioned before. So things like defecation, urination, meiosis. You have the killer bees, which is that bradycardia, bronchorrhea. You can have emesis, lacrimation, and salivation. So those are all symptoms that could potentially be occurring with acetylcholinesterase inhibitors. And then also look at the different mechanisms and know which ones could potentially be utilized together, maybe for some synergistic effects versus which drugs you may potentially not want to use together because they have the same exact mechanism. Next, looking at the GI drugs. We talked about a couple of different kind of disease states which kind of encompass many of the GI drugs that are utilized on a day-to-day basis. So the first one being GERD, GERD symptoms. You do want to be aware of which medications can kind of exacerbate and can cause GERD type symptoms. It's kind of important. So especially things like calcium channel blockers and various medications can be can result in some of these GERD symptoms. So it's important to be aware of that and be able to diagnose that in your patients based on their medication history. Certainly be aware of the different mechanisms of the agents. So things like ranitidine is going to work far different than something like calcium carbonate. And based on that mechanism, you'll know that there'll be different relative potencies of the drugs, and you'll know that certain ones are going to fit better for different therapeutic indications. So obviously, you wouldn't use something like calcium carbonate for healing of an ulcer because we know that the duration of action is not that great, right? Because it works to neutralize immediate acid production, but not on the actual, or it helps to neutralize the acid that's already been produced, but not necessarily to deal with the acid that preventing new production of acid. Beware of adverse effects profiles. So certainly with antacids, if you're worried about, you'd be worried about certain drugs causing diarrhea versus certain ones causing constipation. Depending on their other medication profile, this can actually cause some exacerbation of those symptoms. So say for instance, a patient is on chronic opioids for chronic low back pain, and they are having GERD symptoms, even calcium carbonate. Well, is that going to worsen the constipation that they're already having, or is it potentially going to cause them to have better stooling habits because of the fact that it can cause diarrhea? Those are important things to know when selecting various antacids. Along with that, looking at adverse effect profiles for things like PPIs, because they can have some pretty significant chronic issues. Because those are the most potent agents we have, your proton pump inhibitors. What type of adverse effects can you see from being in a kind of more chronically alkaline GI tract kind of state? It can have problems with calcium absorption. You have issues with bacterial overgrowth and aspiration leading to pneumonias. Lots of things can happen here. So it's important to realize what those specific adverse effects can be based on the individual drugs. And then know where the place in therapy is. If your patient only has intermittent symptoms when they have spicy food, well, do they necessarily need to be on a PPI twice a day? Well, it could be a little bit of overkill. It'll certainly treat the symptoms, but it's also going to be much more expensive and be much more intensive for the patient to take that medication every day. Perhaps they could utilize something that's a little bit more utilized as needed. So maybe something like an antacid might be better for them. Then looking at management of ulcers, so that would include both our NSAID-induced ulcers and our H. pylori-induced ulcers. Be aware of the different management strategies there. So obviously, a strategy to eradicate H. pylori is not going to really work all that well on something that is an ulcer that's produced by NSAID overutilization. So be aware of how those treatments are going to differ. And what drugs are going to be involved in those specific therapies that might be useful for treating them. Then moving on, we have our antiemetics. We know our antiemetics can have several different mechanisms here. So we know that we have things like our 5-HT3 receptor antagonists, like our Zofrans or our dancetrons and granisetrons, work very differently than something like a aprepitant might. Versus something like metoclopramide. So good to know different mechanisms and how which drugs fall into those specific categories. Certainly, adverse effects are going to be really important with antiemetics as well, especially with new things like black box warnings coming on certain drugs. So certainly knowing that things like ondansetron can cause QTC prolongation, and things like metoclopramide, by blocking dopamine receptors, can cause Parkinson-like symptoms due to their extrapyramidal side effects and things like that. And then looking at your laxatives, again, kind of looking at the different varieties of laxatives, different mechanisms of action. It's good to know which ones are not really recommended for different patient groups. So obviously things that aren't going to be absorbed systemically are going to be nice for patients that are pregnant, because you don't want to have a lot of systemic drug absorption and exposure in those type patients. You also want to be aware of which patients shouldn't be getting things like electrolyte-based laxatives. So certainly, you wouldn't want to give, say, an 18-month-old patient a sodium phosphate enema, because that can cause significant electrolyte shifts. So being aware of contraindications, being aware of which medications might be better for different patient groups is good to know. And then certainly know when you can utilize combinations. So obviously you don't want to use two stimulants at the same time, but perhaps by using a stimulant versus and a stool softener, you'll be able to get some synergistic action there. Next, we had our ulcerative colitis and Crohn's disease. It's important to know specifically which medications are going to be effective for the different disease states. So specifically with like things like ulcerative colitis, when can you get away with utilizing something like a rectally administered medication versus when you're going to need much more kind of systemic therapy to cover the entire GI tract. So it's important to know the differences between those. Obviously, something like Crohn's disease, which is going to be kind of intermittently spread throughout the GI tract, you're not going to want to use something that's only going to be able to hit the lower rectum and the distal part of the colon, right? That doesn't make sense. So it's good to know that. Good to know things that you don't want to use to treat chronically. Obviously things like corticosteroids can be very useful for acute exacerbations, but certainly we like to avoid use of those as much as possible in the long term, just due to a lot of the side effects we see there. Things like hyperglycemia and weight gain and changes in mental status and things like that. We just like to avoid those if we can. Certainly be familiar with the monoclonal antibodies that are utilized to treat both of these conditions, and some of the black box warnings and adverse effects that can be associated with them. Namely, by knocking down your immune system with these, TB can be a big risk. So it's important to treat assess your patient for TB prior to starting a lot of these. So things like that are good to know. And then looking at irritable bowel syndrome, because we do have two different subtypes of that with constipation, that with diarrhea, and then you have your untyped kind, and you also have your small intestine bowel, basically the bacterial overgrowth that can occur. It's important to know which medications are good for which subtypes. So obviously you don't want to be giving something that's going to be better at causing diarrhea to patients already having diarrhea. So, again, if you had the clinical situation come up and say, okay, this patient's been diagnosed with IBS, that's been associated with constipation. You obviously don't want to give them a drug like loperamide, loperamide, because we know that it's going to be acting on those opioid receptors and cause decreased peristalsis. So that's just going to make their constipation worse. So again, being aware of how the drugs are working and which subtypes of IBS are going to be useful for it. Then moving into our orthopedics, again, we talked a lot about pain management, and so again, it's a subject that could get whole classes just about that whole subject. But essentially, we would like to know which type of medications can be better for different types of pain. So obviously, IV opioids are always going to be kind of your gold standard for severe pain. But when is it appropriate to utilize something like a tricyclic antidepressant? When is it might be useful to use something like an SNRI like venlafaxine versus does it make sense to utilize acetaminophen for a certain type of pain versus using an NSAID? When would one be more appropriate than another based on mechanism and different things like that? Also, proper management of pain control. So again, looking at things like visual analog scales and looking at different ways to measure pain in a patient. Which way is going to be most effective for that patient? If they're 3, you're going to use a lot different scale than if they're 70 versus if they're 14. So based on that, based on what their mental status is like, based on on their developmental, how developed they are. That can really change how you're going to be assessing that pain. So it's important to be aware of some of the limitations and some of the drawbacks of that. And certainly once you have an assessment of that pain, how are you going to control that? Especially for patients who are having kind of chronic issues with pain, you have to consider doing things like controller medications or controlled release medications that are being given steady blood levels throughout the day, versus and in conjunction with having things like breakthrough medications for when they have those spikes in pain that will happen from time to time. That kind of chronic patient versus someone who's having acute pain issues, obviously they're going to be managed much, much differently, right? We talked a lot about opioids, so certainly be aware of their mechanism of action. Know a lot of the kind of the adverse effects, especially things like, what did they become tolerant to versus what kind of things did they not become tolerant to. That's where we run into a lot of issues with patients who become pain-seeking or pain med-seeking, is due to the fact they've become tolerant to a lot of these effects, and they run into problems when they get higher doses they're not maybe accustomed to. And they can run into problems with that if they don't have complete tolerance to those effects. And then important to know the difference between tolerance and addiction. Tolerance is always going to be one of those things that is expected. It's going to happen for your patients who are on these medications for longer than a few weeks to months. You're going to become tolerant to the effects. You're going to become used to it. Your body's always trying to achieve homeostasis, and so this is no exception. It cannot always be confused with addiction, though. Addiction is much, much different. It's important to realize, is this patient addicted, or are they just not being managed very well for their pain management? And this is why they appear to be drug seeking. It can be very difficult to tell a difference, and especially in healthcare, it's very easy to become cynical about that and just assume everyone's looking for pain meds. But really, there are a significant number of people who don't get treated very well for their pain, and so they kind of get labeled as med seeking, and it can be very detrimental to them in a host of different ways. Moving on from that, then we talked a lot about anticoagulants. We talked about management of VTE and how we can help to correct some of those coagulopathies that occur, especially in the post-operative setting. So certainly being aware of the different mechanisms of the medication, obviously some of the adverse effects that are associated with them, things like bleeding being pretty obvious. But then look at things like, when are the medications going to be indicated? So obviously for an acute prophylaxis, or for an acute event, an acute clot that's occurring, you probably don't want to be starting something like warfarin, right? Because warfarin, we know, takes time to work based on its mechanism. It takes time for your body to metabolize all those clotting factors, and for warfarin to stop to prevent production of new ones. So that takes 2 to 3 days. So that's why you normally will end up seeing patients being controlled or being bridged to warfarin therapy with something like enoxaparin, because that's able to have a more immediate effect on already active clotting factors, while warfarin kind of has a chance to work its way in and be more effective but once those clotting factors are depleted. So being aware of things like that are important to know. And then in the last section, we talked about OB gynecology stuff, basically talking a lot about estrogens, a lot about progestins, probably more than you guys ever wanted to know. But certainly it's important to understand, why are we treating this patient with estrogen-based products? What's our rationale of using, one drug versus another versus combinations of drugs? Know the clinical settings in which it's appropriate to use estrogens by themselves, or when it might be appropriate to use progestins by themselves, or when you'd want to use both at the same time. Like, it's a very important kind of understanding based on your patient history and what their profile looks like. Also want to look at things like the benefits and drawbacks of different dosage forms. So certainly looking at things like local treatment with gels and creams versus patches versus just utilizing oral therapy. This can be a big point for your patients, because they may benefit from a certain dosage form versus another, but if it's really kind of inconvenient to them, or they don't like it, it's not very tolerable to them, it may not be the best dosage form for them based on that. So it's something you have to kind of talk out with your patient and figure out what your goals are and what's going to be tolerated by them. And then obviously be aware of things like the side effects and the contraindications to different estrogens. These can potentially be very, very dangerous drugs, and as such, it's important to make sure that both you and the patient are aware of what could happen. These can kill people based on the coagulopathies that can cause, and it's really important to rule out the contraindications before giving it, because you can miss something really big in some cases. So being aware of those are super important. So anyway, I have not really received any questions as of yet. So if you have anything, please try to get them to me as soon as possible, so I can try to answer them. We'll not be able to guarantee anything up to the last minute, so certainly Monday morning is probably not the best time to ask me questions, but certainly if you can try to get stuff to me beforehand, I will try to answer as promptly as I can. But otherwise, thank you for sticking around. Again, thank you again for the baby gifts. We so appreciate that, and it's so sweet of you guys to do that. And I'll definitely have to get some pictures of my wife with some of the stuff, just so you can just see how happy it made her. It really made her day. But anywho, thanks again for watching, and I'll see you guys on Monday.